Thank you very much. And thank you to the BTS for the invite to come and talk on behalf of a huge team that have put together 3 different programs here in Manchester. So I have the difficult task of covering what could be a whole afternoon's talk on these programs. So forgive the briefness of them, and I'm very happy to take any questions or discussions afterwards, given that limited time. So I named the talk, this Launching an Assault on Lung Cancer in Greater Manchester. And that came out of the very firm, passionate belief that to make any inroads into the terrible outcomes in lung cancer, we would need a multifaceted approach that would include trying to prevent lung cancer from happening in the first place, diagnosing at a stage where it is curable and treatable, whereas currently the vast majority are diagnosed at an advanced incurable stage, and providing an accelerated pathway through when lung cancer is suspected through to diagnosis and treatment. And that's been the kind of the birth of the CURE program, the lung health checks, and the RAPID program. Then I'm going to touch on each of those 3. So the story for all of these started when we found this information from Public Health in Greater Manchester, and it goes pretty much into any talk that myself or any of the other team members give, which are the causes of premature death in Greater Manchester. So Public Health England will define that you've died prematurely if it is under the age of 75. And lung cancer is the single biggest cause of premature death in this region. And there are many other cities around the country that have the same statistic. And the top 3 causes of lung cancer, heart disease, and lung disease have their roots in tobacco addiction. So if we were trying to do something substantial to impact the health and well-being of our community, they're the diseases we need to address. So the CURE program I'm going to start on, which focuses in on tobacco addiction, and we've heard about the importance that secondary care has to play, the teachable moment when a smoker is admitted to hospital out of their normal environment of smoking, their normal cues to smoke, and a teachable moment of unique motivation to try and help them to stop smoking. We've known this for a long period of time. What the CURE program started to build on the foundation of what's happened in Ottawa in Canada. So the Ottawa model of smoking cessation, which was nothing complex, but they simply did the basics very well, and they did it at scale. So in Ottawa, they systematically identified smokers that were admitted to hospital, and they offered them help with both support and medications systematically, and then offered help after discharge as well. And they showed that these were not benefits that they reaped 20 years in advance in the future. The benefits were immediate. They immediately started saving hospital admissions and immediately started saving lives. And so we took the benefits from Ottawa and put them into Greater Manchester's data and said, if we reaped the same benefits, what would that look like? And this is simply focusing on secondary care admissions and readmissions saved and lives saved, regardless of all the other benefits that stopping smoking would bring. So in Greater Manchester, we'd save over 3,000 admissions a year, 6,000 lives a year. No other health intervention can provide that level of benefit that quickly. Taking the average cost of hospital admissions at nearly £10 million of savings, 30,000 bed days per year, 84 extra beds every day across Greater Manchester. And it's these figures that got our hospital executives and commissioners interested. And that's what the CURE program was born from. And CURE stands for having the right conversation every time, understanding the level of addiction, replacing nicotine, and having access to experts in evidence-based medicine. The word cure was specifically chosen to medicalise this condition. I rarely use the term smoking cessation and use the term tobacco addiction to reflect the disease of addiction to tobacco, the chronic relapsing disease that very often starts in childhood. And that chronic disease is the responsibility of all clinicians, and we can all learn about the evidence base to treat this disease, provide access to those medications. Whereas previously we've always been taught that our role is to tell someone to stop smoking and to say they should go and see someone for behavioural support for their lifestyle choice. This is a disease that as clinicians we can treat and support it with that specialist support. So the CURE pathway means that we want every patient that comes into a hospital setting to be screened. And if they are a smoker, that's recorded and robustly recorded. And that it should be an opt-out model. So every smoker is referred to a specialist team. That smoker is provided with brief advice. This is not about telling them to stop, it's about offering help. We use 2 simple questions about how many someone smokes and how quickly they smoke from waking up to define them as low, moderate or high level of addiction. And each one can map to a specific NRT prescription. So you can really protocolize this at the front door for the teams that are admitting patients in the hospital, just adding a few extra minutes onto that initial clerking. And offering varenicline, which is a highly, highly effective medication, which is Champix for tobacco addiction. Now, to do that, we have to give people the confidence and the competence to be able to do that. So they need training. We need to train our frontline staff to do that, which is exactly what we've done. That's then supported by a specialist team who can go and spend more time with that smoker, go through that more detailed history of their smoking history, what's been tried before, how is that NRT working, does it need to be changed, what other medications are needed, and then they need to be followed up after discharge. And in our Cure pilot that's been running over the last 6 months at Wythenshawe Hospital, we follow people up at 2, 4 and 12 weeks after their admission. So the BTS probably did the best bit of work I've seen about what happens currently in treating smokers that come into hospital in 2016, and their conclusion is that it was woefully inadequate across the country. So 5% of smokers were getting access to either treatment or specialists. In the first 5 months of our Cure programme, there was nearly 2,000 smokers admitted to Wythenshawe. The opportunity to intervene with 2,000 smokers. 95% provided with intervention by the admitting nurse, nearly half provided by NRT by the admitting team, not even the specialist team, the admitting clinicians. Half of smokers will say, yeah, I need some NRT for this admission. If you approach every single smoker, half will say, yes, I do want some help, I want that specialist, and I want following up. We were prescribing no varenicline in hospital before, it's now up to 10%, and our Cure team are adding in medications and changes in over 500 of those cases. And the quit rate in those people supported by the by the Cure team at 4 weeks is 47%. We can show we can change systems, change a hospital culture to make this everybody's responsibility and reap the benefits from it. On the basis of that, Cure is now rolling out across Greater Manchester. We have transformational health funds to be able to do that, just over £2 million, and these are the first 6 hospitals that will be up and running soon. There is lots more information on the Cure website, thecureproject.co.uk. The training modules are on there, all our pathways and treatment protocols are on there. Stop for breath. Lung health checks. So picking lung cancer up at a stage where it can be cured to truly impact on the most deadly solid tumour that there is. We have 2 randomised control trials from America and Europe that shows this saves lives. That is in no doubt. We now need to learn how to implement this properly. And the biggest challenge has been how do you reach the hard to reach, where smoking and deprivation is most at its prevalent and where lung cancer is most at its prevalent. So this was a project to try and understand that, how we best access that group. By putting lung health checks into the most deprived areas in Manchester, and people being invited for a lung health check where there's spirometry, there's a symptom assessment, whole bunch of health interventions recorded, but one of those is a risk of lung cancer over the next 6 years, the PLCO risk calculator. And if your risk is above a certain level, the CT scanner is there, mobile ultra low dose CT, just walk into the next van and have your CT then and there. And this was run as a pilot funded by Macmillan to their great credit, and showed a significant stage shift. 50% of patients with symptomatic lung cancer present at stage 4. The blue bars is what is happening currently. The red bars is what happens in the lung health check. So a significant stage shift towards the majority being diagnosed at stage 1 and at stage 2. The detection rate's 4.4%, 65 lung cancers in 61 individuals. We were doing around 40 scans a day, which means we were picking up at least 1 cancer per day of scanning. And the vast majority received curative intent treatment. And what has been learnt from those, from the evidence base is now how we minimise the potential harms around false positives, because we've got good nodule management now, thanks to the work of the BTS. That prevents benign surgical resections. There's a lot more information on, so there's 2 publications in Thorax about our baseline round and T1 round, if you'd like more information. And we know that NHS England is rolling that out. We have a site here in Manchester in Tameside, and our lung health check programme has been commissioned for the north of Manchester, which launched this month, and to be rolled out in central and south Manchester in the future. So the last thing to touch on is the accelerated pathways, our RAPID programme. We currently, cancer pathways tell us if you're referred with suspected cancer, then you should be seen by a specialist within 14 days, and then you should start your treatment within 62 days. And I think there's a unanimous support that that is not the length of time we would wish for ourselves or loved ones, and certainly not an appropriate time for the most deadly solid tumour. There's a growing evidence base that time is a critical factor on a lung cancer pathway. And we were acutely aware that nobody wants a delayed pathway, but there are inherent system delays simply to get a referral to a booking centre, to get to a team that have to request a CT scan, to then that CT scan being done, to being reported, to being in clinic, very disjointed, even very front end of the pathway. So our RAPID programme was about trying to take those system delays out. So what happens is when we receive a GP referral or a chest x-ray upgrade, the patient is phoned and asked to attend the following morning at 8 o'clock the next day. They have their CT scan, and that's facilitated by having things like finger prick renal function, so it takes out the renal function problems. The scan is hot reported with the patient on the table, so the radiologist is looking at low-dose CT scans without contrast. And if there's no cancer on them, they don't need contrast, they can get off the table, you minimise radiation. Whereas there is something, contrast is given, they have a full staging scan. The patient then comes down to us in our clinical area, and we can see them with that CT scan result. We can tell the 3/4 of people referred that they don't have lung cancer the same day as their CT scan. And for those where we do suspect lung cancer, we can get their pathway commenced with test bundles, and we have patient navigators to oversee that process. What I've described is largely the front end of the pathway, so by doing nothing else other than addressing that very front part, we've managed to bring that lung cancer pathway down significantly. So there is a national optimal lung cancer pathway that we are 82% compliant with at the 50 days. Our ambition is a 28-day pathway, which currently sits around 50%. And that is where we need to address other areas of the pathway. We're always challenged that is it a good patient experience or are things too quick? So we asked 1,000 patients who had been through this service that, given your GP wondered about the possibility of cancer, when would you expect to have all your tests done and have answers? Given currently, that's 4 weeks and beyond. Patients expect this within a week or 2 weeks, 90% do. There's a separation between patient expectations and targets. But we show we're able to do this with good satisfaction. The vast majority say the speed of the service is just right. For a small proportion, it's too quick, and you have to adjust for that, but it's a very small number, and for a small number, it's not quick enough. We launched this in 2016, and we have the National Lung Cancer Audit that publishes data beyond a year in advance, so there is a time lag between getting data. But we were contacted at the end of when they published the 2016 data to say you're an outlier. That normally means you're a negative outlier and there needs to be an action plan. But we are a positive outlier for 1 year survival across the country at 50%. And I believe that the RAPID programme is a big part of that. We know lung cancer has the worst 1 year survival of all cancers, but accelerated pathways have the potential to bring that up. Yeah. And that's going to roll out across Greater Manchester. So I always finish just with, this is a quote from Benjamin Disraeli, who apparently said this on the steps just outside this conference hall, talking about the Industrial Revolution, that the age of ruins is past, and have you seen Manchester? What Manchester does today, the rest of the world does tomorrow. So I hope that is true.